So, good morning for all the young friends over here. So, I'm going to be speaking on retinopathy of prematurity. So, before I begin my talk, I just would like to know how many of you are term born, how many of you are preterm here? Because before I start, I should know, no, how many term children I'm speaking to, how many preterm. So, the term figure is more, and the preterm. So good, there are a good number of preterms here. So yeah. So I would like to tell you that I am a preterm child. Yes. So a 32 weeker. So no ROP. Though not screened, that's the correct thing. So what is retinopathy of prematurity? It is nothing but it is a vascular or incompletely vascularized retina. That is what is retinopathy of prematurity. When does it occur? It occurs 4 to 5 weeks after birth. So you may talk about corrected gestational age, post menstrual age, all those things. We'll come to it a little later, but just remember 4 to 5 weeks after birth is the time when it is crucial for development of retinopathy of prematurity. And it can lead to blindness. Yes, by 12 weeks of life, it can cause blindness. So that is why it is important. It is one of the preventable childhood blindness. And you have a very limited window of opportunity. So we must capture on this window. So before I dwell into ROP per se, let us understand some definitions here. What is abortion? Abortion is 20 weeks. And what is infant viability? Infant viability is gestational age of about 25 weeks and a birth weight which is more than 600 grams. And there is a gray zone here. Why do we have a gray zone here? That is because nowadays children are more surviving because of the thanks to the NICU cares. So we are having babies who are surviving are at gestational age of 23 to 24 weeks and a gestational age of 23 to 24 and a birth weight of 500 to 599 grams. So this is what we are current situation. So they are born too soon. What is the strategy that is being followed? Simple is to remember 30-day strategy or a 20-day strategy. 30 days is for babies who are at 34 to 35 weeks of gestation and a birth weight less than 2000 grams. And a 20-day strategy is followed for less than 30-week gestational age and for a birth weight that is less than 1500 grams. So here specifically I have not put these gray zone babies whom I described as 23 to 24 weeks. For them you must remember that the cornea is also immature, so the clarity may not be there. The tunica vasculosa lentis will be present, so it might be difficult for you to see through for those babies at this point in time. So what are the sub classifications of the preterm birth per se? Extreme preterm is less than 28 weeks, very preterm is 28 weeks to 32 weeks, and a moderate to late preterm is 32 to 37 weeks. Now, what are the pathophysiology? So, to understand the retinopathy of prematurity, you must understand the three phases. So, a compromised physiological vascularity. So, that is what is the key thing in this development of ROP. So, phase 1 is what? Delayed physiological retinal vascular development. So, there is a delay in the physiological vascular development. In phase 2, you tend to have intravitreal angiogenesis. So this is what we would like to prevent from occurring, phase 2. And phase 3 is what? Retinal detachment from vitreoretinal traction. This is what you don't want it to occur. So your treatment starts in the phase 1. So phase 1 is for monitoring. Phase 2 you must try to prevent. Phase 3 you don't want it. Now, this is the classification of the ROP, wherein you can see at different points in time. We are currently at the ICROP 3. They have defined the location, the extent, the stages, and the stages of 1 to 5, the threshold, the pre-threshold, and then the APROP, now so-called AROP. Before that, we should have the preparation of the babies. So what are we going to do? We should dilate the pupil. How do we do that? There are different medications that is available. Cyclopentolate, phenylephrine, the concentration I've written. I think Partho is going to give you all the slides, so you can probably have these as a handprint. So these are all the drugs which one could use for the dilatation of these babies. And you must remember, when you are doing these examinations, it is mandatory that one should probably have it under the care of the anesthetist or the neonatologist, so that in case the baby develops a problem, they can receive immediate attention. The instrumentations are the Alfonso speculum, the wire vectis, the 28D lens or the 20D lens, and the propercaine drops that is to be used. And what is the first screening guideline? So gestational age 34 weeks or less than 30 days, and a gestational age of more than 34 weeks if it is exposed to risk factors, then at 30 days. If gestational age is not known, then the birth weight is less than 2000 grams, then also at 30 days. If an infant is less than 1000 grams, 200 grams, or a gestational age less than 28 weeks, then the 20-day strategy has to be followed. All other preterm babies, at the discretion of the pediatrician or the neonatologist, the screening has to be done. So what are the models of screening? So models of screening are retinologist based and retinologist driven. There are two ways of doing it. So you can do a tele ROP as well, when you can use the cameras, RedCam camera that is available. Post mydriasis, one can do that from remote also. It is being practiced. And what are the various modalities by which one can do the screening? You have the video indirect ophthalmoscopy, the RedCam 3, 3 Netra, ultraviolet photography, Phoenix Icon, and the M2 RedCam and the Pictor. These are all the things available for the screening of the ROP. And the examination technique is how you swaddle the baby, keep the temperature. Hypothermia should not occur. The baby should be warm. And then, as I told you, the neonatologist or the pediatrician or the anesthetist must be available when the screening is done. And you must remember, we are all facing what is called as the epidemic of ROP. The first epidemic was somewhere in 1940 when unmonitored oxygen was being given. The second epidemic was for the prematurity, was on the rise when there was a lot of babies born less than 1000 grams in the developed countries. And we are currently at the third epidemic, where we have premature, bigger babies developing ROP. So this is what current situation of ROP is. Now, what are the guidelines? The global guidelines are different from Indian guidelines. Why? Because ROP is diversified. Every NICU has a varying tendency of treatment. So we tend to differ in terms of the guidelines. So for us currently, any baby less than 34 weeker, less than 1750 gram dictates a monitoring, and a baby who is 34 to 36 weeker, 1750 to 2000 grams, if declared a high risk baby, that also requires screening. So now, what are the zones of screening? So those zones of screening are described with a 28D diopter lens. Anything that with a disc centered, if whatever you see is in zone 1. And when you say now the zone 2, posterior zone 2 is the latest discrimination which is being done, which means posterior zone 2 is 2 disc diameter from zone 1, and anything a little beyond at the mid equator is zone 2. Only the temporal crescent, that is the zone 3. So this is how you describe the zones. So, and now coming to staging, anything that is at the plane of the retina where you just see a demarcation between the vascular and the avascular margin, so that is called stage 1. And anything that goes a little bit on its height, which grows on its width, when you can see on the OCT here on the third slide. So that will show you that there is a little bit of a width that is catching up, that is zone 2. And anything that is picked up in height, that is stage 3. So stage 3 means you have extra retinal vascular proliferation, and this is the stage 1 would like to treat. Stage 1, stage 2, we don't treat. And the stage 4 and the stage 5 is what you are trying to prevent. Stage 4A is sparing the fovea, tractional retinal detachment. So these are not regardees, these are not exudative detachments, they are tractional detachments. And when it is involving the fovea, it is stage 4B. When it becomes a total detachment, that is stage 5. So the stage 5 is again in different configurations. It could be in open configuration is what you see on the first panel, and the second panel is closed, which means anteriorly closed, posteriorly closed. And the third one is open anteriorly but closed posteriorly. And the fourth one is closed anteriorly and open posteriorly. Now, yet another configuration is the 5A, 5B, 5C, where when you have optic disc that is visible, that is 5A, optic disc that is not visible, that is 5B, and when you have anterior segment abnormalities like anterior lens displacement, marked AC shallowing, or iridocapsular adhesions, these are on 5C. Now, Beyond all this zoning and staging, we also have whether the baby has got a plus disease, yes or no. So what do you mean by plus disease? This is nothing but engorgement and dilatation of the vessels. You might have the pupil that is rigid, engorged iris vessels, vitreous haze. These are all occurring a little later. So but to say that these are nothing but dilatation of vessels. So now a pre plus is something which does not qualify for a plus, is a pre plus. To put it in short, these are a continuous spectrum of diseases. So you can see that if you are seeing, see from here, you see the vascularity keeps increasing. So you know that this is a continuous spectrum of vascular engorgement. So if it increases, please remember these are to be treated. So now when I say staged ROP versus an unstaged ROP, staged ROP when it goes through stage 1, stage 2, stage 3. But unstaged ROP is what is called as AROP, wherein you just have dilatation of vessels and then it quickly goes into the proliferative stage. So these are all the babies who are either in zone 1 or zone 2. They are never in zone 3. So one would not get in zone 3 a plus disease or an AROP never occurs in that. So that is what it is. A notch is something which occurs in a zone 2 with a caving in, which you have seen. So this is called a notch which is there. So now to understand what is zone 1 and what is zone 2. So zone 1 is vasculogenic, that is driven. Zone 2 is angiogenic. So vasculogenic means what? So vasculogenesis is nothing but de novo origination of a vasculature from the endothelial cells. Whereas angiogenesis is what? Angiogenesis is something to understand that if it does not occur, you will tend to have non-proliferation of the capillary zone. That is what it is to say. So now when you say treatable ROP, when you have to treat, it is type 1 ROP. Anything in zone 1, stage 1, 2 or 3 with plus to be treated. Zone 1, stage 3 ROP without plus also requires treatment. Zone 2, stage 2 or 3 with plus requires treatment. AROP in any zone requires treatment. What are the mode of treatment that is being followed? It's either the laser or the anti-VEGF. Remember, posterior disease is better treated with anti-VEGF. Anterior diseases are better treated with laser. So zone 2 and zone 3, very well take it down with laser, and zone 1 diseases or half zone diseases are better treated with intravitreal anti-VEGF. What is the mode of action? When you give anti-VEGF, it inhibits the stage 3 and the plus disease, extends the physiological maturity. And in laser, it inhibits the stage 3 and the plus disease. Now, the intravitreal pharmacotherapy, the drugs that are being used are bevacizumab, ranibizumab, aflibercept. And how do we follow up? The treatment regression for a baby who is being laser treatment is different from an anti-VEGF. So the treatment is different and also the way of follow-up is different. So when you are giving anti-VEGF, remember the babies are to be followed every weekly until 44 weeks and for fortnightly until PMA is 52 weeks. The postmenstrual age is what is PMA. Monthly until it becomes normal or reactivation. So the baby is to be stopped screening only after it becomes normal, or if you get a reactivation, then treat it at the stage of reactivation. So reactivations are known to occur with bevacizumab from the BEAT trial. You understand it can be anywhere from 16 weeks to 35 weeks after treatment. So what is reactivation? When you give anti-VEGF treatment, they are more to reactivate than the spontaneous regression or the complete laser photocoagulation. So it does not go through the stages. So this is a little slow. Reactivation takes its own time. What are the long-term sequelae? You could develop a late retinal traction, or you could have retinoschisis, persistent vascular retina, macular abnormalities, or retinal vascular changes like macular dragging, falciform fold, or glaucoma, the secondary angle closure. So the physiological course of ROP, which I've been describing, is acute phase, the regression, the reactivation, and the late complication. Who should do the screening? This is very important. A person who's either trained in a vitreoretinal surgery or a medical retina person or an ophthalmologist who has a special training in ROP are the only people who are allowed to treat retinopathy of prematurity. And this is the first study which came in India, which was to say that retinopathy of prematurity is in India. So this was in 1995. It was by none other than by Dr. Lingam Gopal sir, who is described as the father of Indian ROP. Now, not to forget, ROP is one disease which has got the maximum legal battles which are there, and these are all the cases which you can see. Up to 1.8 crores has been the compensation that has been advised. So if any of you see a preterm child and not referred to an ROP specialist, then that becomes your responsibility, because you will also be sued. So remember, if any of you see ROP children in your practice, please refer it to the person who should take care and document it well, because if you miss a documentation, that is going to be an error. So now how do you follow? Immature children are bi-weekly and pre-threshold is 1 to 3 to 7 days. And if you have given anti-VEGF, you need to remember that a longer meticulous follow-up. Retinal detachment needs early surgical treatment. And at 6 months of age, remember, refractive error and squint has to be evaluated. So in summary, ROP is incompletely vascularized retina at birth, evolves at 4 to 5 weeks after birth, can lead to blindness by 12th week, limited window of opportunity, highest legal complication, documentation is crucial, and timely referral is essential. Thank you.